for you now. Let me introduce our two speakers. So in this corner, we have Dr. Aslam Amod, graduated from the University of Natal and holds fellowship from both the College of Physicians of South Africa and the Royal College of Physicians in London. He's a consultant endocrinologist at the Life Chatsmith Hospital and a lecturer at Nelson R. Mandela School of Medicine. I think Aslam is well known to all of you from Durban and many people in the medical community around the country with his involvement in the South African Diabetic and Endocrine Society, as well as his role in guideline development in South Africa. In that corner, we have Dr. Ebrahim Mansoor. Dr. Mansoor is a general and bariatric surgeon at Amod Private Hospital in Durban. He completed his undergraduate studies cum laude at the University of KZN and went on to complete his fellowship in surgery. Furthermore, he has received training from several countries around the world, and his main interest is in the management of obesity. He was the first to introduce intragastric balloons in South Africa and has gone on to offer a full spectrum of obesity treatments. So we have two excellent speakers. The format is going to be both are going to give us their side of the story. One is just going to cure your obesity with a few pricks of the needle and a bit of soothsaying to your body, and the other one is going to cut the fat out of you. But inshallah, at the end, we will have a way forward for all of our patients with obesity. So we welcome Aslam to start.
Assalamu alaikum. So, I need to have my laptop here because with age, your vision goes, so I can't actually see the screen there in front. Okay. So, which is the silver bullet and which is the slippery slope? Surgery versus medical therapy for the treatment of obesity. So these are my disclosures, and as you can see there, I accept bribes from all the companies equally, and that tends to keep me honest. So just as a background, so obesity is a global epidemic, one of the fastest growing epidemics around, and in South Africa we're not spared. About 50% of adult females in South Africa are either overweight or obese. And the figure in the next 10 years is going to increase dramatically. At the moment it's about 1 in 5 males, but that will increase by more than 85% over the next 10 years or so. Now, in terms of weight loss, it's important to recognize what we're trying to achieve and how we go about achieving it. So if you lose less than 5% of your body weight in a person who's obese, then you might get very slight improvements in metabolic control. Blood sugar values might come down a little bit, and your blood pressure might decrease by about 4 to 6 millimeters of mercury. But nothing more than that. We have no impact at less than 5% body weight loss on the major outcomes with obesity. So in order to start to have an effect on things like polycystic ovary syndrome, fertility rates in these patients, fatty liver disease, you need to lose about 10% of your body weight. And then if you really want to start to impact on cardiovascular disease, steatohepatitis, which is not just simple fatty liver disease, things like obstructive sleep apnea and so forth, then you need to lose about 15% body weight. And to make really a sizable difference in your health outcomes and in terms of mortality, cardiovascular disease, and even remitting your diabetes. In other words, diabetes we recognize now as being curable. In a person who's had a diabetes for less than 10 years and is not yet insulin requiring, and that person is obese, it is possible for that person to reverse their diabetes. But you need then 15% of your body weight loss in order to achieve that. Historically, weight loss has been an extremely difficult thing to achieve in our patients. And it's a very simple reason. This is a complex neurohormonal pathways that protect your maximum body weight. That's the evolution of humans. The evolution of the human brain and the human body is that it will always protect the maximum weight that you achieve. So your brain never loses the memory of what the maximum weight you reached was. And the moment you start to lose weight, all of these mechanisms will kick into action to try and return you to that weight, because it perceives that when you're losing weight that you're in a famine and that you're going to die of starvation. And so that's the mechanism, and that's why it's so difficult to lose weight, is because you're fighting against physiology. And it's a reason why lifestyle intervention, so we always say, counsel the patient, give them advice, they need to lose weight, all well and good, but we all know from day-to-day practice it doesn't really work. Very few patients do it. And even when you do intensive lifestyle modification, you send a patient to a dietitian 6 times a year or every month and see a biokineticist and all of those fancy interventions, then listed on the slide is the kind of intensive lifestyle intervention that you require. But even then, as was shown in the Look Ahead study, the Look Ahead study intervened in patients who are overweight, obese, with intensive lifestyle modification, nothing near what we could afford for our patients, in terms of personal dietitian, biokineticist, and all of that. And still, at the end of 10 years, they lost 4 kilograms in 10 years. So it's difficult. So lifestyle, we should encourage that all the time. I think it plays a bigger role in preventing obesity than in treating obesity. So in terms of the older drugs now, if you look at pre-2015 era, we had some drugs to treat obesity, but they weren't very effective. None of them caused more than 10% body weight loss. And they had a whole host of side effects. So Orlistat used to cause diarrhea, flatulence, oil leaks. So the patient, without knowing it, would mess the soil, the underwear, because it caused fat malabsorption, and this fat leaked out as oil. Then you have phentermine or duramine, which has tachyphylaxis, so you take it for 3 months and then it stops working, causes urinary detention, tachycardia, so the older medications that we had were fraught with side effects. Patients didn't do well on them, and even if they did do well, they did well only temporarily. And this is where surgery found its place, because since the early 2000s, bariatric surgery came into vogue, and it was far superior than any of the treatments that we had. It was superior to lifestyle modification. It was superior to the older drugs that we had, and you could lose 20% body weight with the bariatric surgery, and it led to improvements in a whole host of metabolic parameters as well, and decreased cardiovascular risk factors, and so it became the standard for the management of obesity. So it's long been regarded as the most effective treatment that we have for obesity, and it causes substantial long-term weight loss, and it has proven efficacy for obesity-related comorbidities such as hypertension, diabetes, albeit mainly from retrospective studies though. There have been very few prospective studies when it comes to bariatric surgery. But nevertheless, if you put all of the data together, it's effective. So the indications then for bariatric surgery is anyone who has a BMI above 40. And if you have a BMI above 35, then you need to have some other obesity-related comorbidity with that. And for people with a lower BMI, between 30 and 35, then you need to have either diabetes or the full-blown metabolic syndrome, which has failed medical therapy. The commonest bariatric procedure is sleeve gastrectomy. It's now in 2025 the most commonly performed bariatric procedure, as opposed to the Roux-en-Y gastric bypass and the biliary pancreatic diversion. That's hardly performed at the moment. So these are the two main ones, but sleeve gastrectomy is the commonest. It's technically easier. There's no anastomosis required. Short surgical time, laparoscopic procedure. You preserve the anatomy of the small bowel if you do just a sleeve gastrectomy, and there's less dumping syndrome, and patients generally have a better quality of life with the sleeve gastrectomy. But surgical procedures are irreversible. That's the one thing. And the second thing is that, especially with sleeve gastrectomy, there is a risk, a definite measurable risk of severe gastroesophageal reflux disease and Barrett's esophagus. So if you were to look at the efficacy of these two procedures, this is a comparative analysis now of the two procedures taken from a meta-analysis of 18 trials, 9 of which were randomized controlled trials and 9 of which were non-randomized trials. But the total number of patients in this meta-analysis is about 3,000 patients. I want you to remember that figure because it's not that big a figure when you look at the quality of the data that we have. But nevertheless, in terms of the percentage of excess body weight loss, the two procedures are not very different. Whether you have a laparoscopic sleeve gastrectomy or a Roux-en-Y gastric bypass, the percent of excess body weight is roughly the same. Now, you will hear from my colleague, the surgeons like talking about percentage of excess body weight loss. And so you hear figures like the patient lost 70% of their body weight and 60% and 90%. So if a person who weighs 100 kilograms has an ideal body weight of 75 kilograms, then their excess body weight is 25 kilograms. And so if you say they lost 70% of that, then 70% of 25 kilograms, not 70% of their 100 kilograms, right? So the medical literature differs in that we talk about percentage of total body weight loss. So when you say you lost 20% of your body weight, if you weighed 140 kilograms, then it's 20% of that, not of just the excess body weight. Diabetes remission rates for these surgical procedures were not different. About 60 to 70% of patients will have remission of their diabetes. The early post-op complications are higher with Roux-en-Y. The late post-op complications, there's no difference. Reoperation rates are much higher with the Roux-en-Y gastric bypass. And the Roux-en-Y gastric bypass, however, might be a little bit better at improving other metabolic parameters. But in general, in terms of the weight loss and the lower complication rates, I think there's very little to debate there that the sleeve gastrectomy is a better option. So in terms of 5-year outcomes, looking at weight loss, you will see here that the sleeve gastrectomy, you have a slightly less body weight loss, about 4 kilograms at the end of 5 years. So at all time points, Roux-en-Y gastric bypass in this analysis had a very, very slight advantage. So you're looking at 23.7% weight loss at 5 years versus 27.2, but there's an overlap there, so whether that's statistically significant or not is debatable. But certainly the complication rate is statistically significantly higher with Roux-en-Y. So sleeve gastrectomy is the way to go. Now, the complications and mortality, you can see here, that require intervention following a sleeve gastrectomy was about 10% of patients required some form of intervention, slightly higher in the Roux-en-Y, and mortality was about 2 out of 228 patients in the sleeve gastrectomy and 4 out of 229 patients in the gastric bypass group. In terms of, again, in this analysis, total body weight loss, very little to argue about. For diabetes remission, little to argue about. Dyslipidemia, slightly better for Roux-en-Y. But about 20% for surgical interventions, 1 out of 5 patients will not achieve the optimal weight loss. Okay, they won't reach their target. And for those that do lose weight, 50% will regain more than 10% of the weight from the nadir. And Barrett's esophagus occurs in about 15% of patients with metaplasia. And percentage of patients, 15% at 10 years, required to convert their sleeve gastrectomy to a Roux-en-Y because of severe gastroesophageal reflux disease. In terms of major complications, early complications, you're looking at a 5%. Oopsie, sorry. I'm changing my computer. I'm forgetting to change it here. Apologies. Okay. Yeah. So in terms of early complications, 30 days, about 5% of patients have major early complications with both procedures. About 5% require reoperation. You've got unplanned emergency visits in about 7.5% of patients, and late reoperations in about 0.3% of patients with sleeve gastrectomy, and higher with Roux-en-Y. And further on down the line, they need cholecystectomy in about 10%, and the procedure-related mortality is about 0.2% for sleeve gastrectomy and 1.2% for Roux-en-Y. So, the new kids on the block, from the medical point of view, are what we call the peptide hormones, and these consist mainly of GLP-1 receptor agonists, also GIP, glucagon inhibitory glucose-dependent insulin-tropic polypeptide hormones. These are incretin hormones produced by the bowel in response to eating, and the effect is to stimulate insulin secretion so that you can digest your food. However, in suprapharmacological doses, they delay gastric emptying, so you feel fuller for longer, and it has a central effect, so you, in the satiety center, so that makes you feel fuller as well. And this is how they lead to weight loss. They're now being combined with other hormones that I'll show you. So it's not only GLP-1 and GIP, but it's now glucagon receptor agonists and amylin receptor agonists as well. So these are the drugs that are available. So liraglutide, which is Victoza, but in a higher dose. So there's a diabetes dose for many of these drugs, and there's a weight loss dose. So the weight loss dose tends to be a much higher dose than what we use just to control blood glucose. And so with liraglutide, we've got Victoza and Saxenda. With semaglutide, we've got Ozempic and Wegovy. With oral semaglutide is Rybelsus, not yet available in South Africa. There's orforglipron, which is also an oral agent not available in South Africa. Tirzepatide is Mounjaro, which was launched earlier this year in South Africa. It's a combined GLP-1 and GIP agonist. CagriSema is a combined amylin and GLP receptor agonist. And there's retatrutide, which is a triagonist, triple, GLP, GIP, and glucagon. And so they add to each other in terms of efficacy. And so rather than show you, each of the separate studies, I've summarized in this table the studies that have been performed in people with obesity, with or without diabetes. And as you can see, the numbers of patients in these studies is quite large. The duration has ranged from 70 months to about 4 years. And the weight loss has ranged from 8.4 kilograms to 26.2 kilograms. And if you look at the percentage body weight loss, again, it's from about 10% to about 25% body weight loss, with the higher values occurring with tirzepatide and Mounjaro, then CagriSema and retatrutide. Now so this is about 35,000 patients in prospective randomized controlled trials, right? And remember the figure I showed you for surgery was for randomized controlled prospective studies was about 3,000. So this is level 1A evidence that these drugs cause significant weight loss, which is either equivalent to or greater than laparoscopic sleeve gastrectomy or Roux-en-Y gastric bypass. So just to show you a little bit more detail, this is the study. So these from the retatrutide study, and you can see that the mean weight loss at the highest dose of this drug was 23 to 25% of body weight, and that the percentage of people achieving more than 20, 25 or 30% body weight on the highest dose was 60%, 50% and 25%. Okay? And then, oops, sorry. So there's, sorry, that's the figure there. So, and then this is a study with CagriSema, also showing you about 23% body weight loss with CagriSema, and again, the percentage of patients who are losing more than 20, 25, and 30% body weight is shown there. So 6 out of 10 patients lost more than 20%, 4 out of 10 patients lost more than 25% body weight, and 1 out of 4 lost more than 30% body weight. So if you look at the weight loss that one is getting now with the later generation of these drugs, then the percentage body weight loss, as I said, is either equivalent to or greater than surgery. And if you look at what are the other things that you need to know about these drugs, well, GI side effects are common. Patients get diarrhea, constipation, bloating, dyspepsia, and so forth, but they tend to be temporary. And in the majority, so you can expect about 1 out of 3 patients will get GI side effects when you initiate these drugs, but you initiate low and you gradually titrate, and then these side effects generally pass. But about 5 to 10% of patients will end up not tolerating the drug, and they won't be able to continue with the drug. Okay, but up to 90% of patients will continue. These drugs have been shown to prevent diabetes, so if you use them in people with pre-diabetes, then the prevention rate at the end of the studies showed that 95% of patients who had pre-diabetes revert to normal. So whether it's impaired glucose tolerance or whether it's impaired fasting glucose, they revert to normal. In terms of diabetes remission rates are up to 70%. So 70% of people with diabetes will end up with a hemoglobin A1C in the normal range, which is below 5.7%. Okay? In terms of other outcomes, there are cardiovascular outcomes trials showing you that they reduce major adverse cardiovascular events, that is stroke, myocardial infarction, and cardiovascular death by about 20%. They reduce obstructive sleep apnea, they reduce heart failure, and they reduce steatohepatitis as well. And so this has been shown both in people with obesity without diabetes and in people with diabetes. In terms of comparing this, so these drugs can be prescribed by any medical practitioner to any patient who can afford it and who wants to lose the weight. In terms of metabolic surgery, before you go for metabolic surgery, you need a report from an endocrinologist, a physician, you need a report from a bariatric surgeon, you need an ultrasound, you need gastroscopy, you need a clinical psychologist report or a psychiatrist report, you need extensive blood workup, a report from biokineticists and physiotherapists, you need sleep apnea studies, you need a dietitian's report, and you need a pre-op anesthetic and cardiologist report before you can embark on bariatric surgery. And then you often, in the very obese patients, want them to lose some weight, so you put them on a drug before they can go for surgery. Then you've got the cost of surgery, the cost of hospitalization, you've got the immediate post-op complications, you're dealing with a mortality rate of about 0.15 at least, early complications in 5% of the patients, early reoperations in about 5% of patients. You have to deal with late complications, you have to deal with the non-responders, who about 10 to 20% of patients who won't lose weight, revision surgery that is necessary, post-op cosmetic surgery because they lose the weight too rapidly, and then they end up with all this lax skin everywhere that needs to be corrected as well. And they need lifelong follow-up, something which is largely neglected by many surgeons, I'm sure not my contender today, but surgeons do the operation and then they forget about the patient, and then we deal with the problems 10 years later or 5 years later. But these patients, once you have bariatric surgery, you have to have good follow-up at least every 6 months. And then they need lifelong vitamin supplements as well. So, if we look at this is just summarizing the non-responder rate, and as you can see, it's quite significant. The percentage of patients who don't lose more than 20% body weight, the ones who regain body weight after the initial loss, and the ones who return to their baseline weight by 5 to 10 years. 10 to 20% of patients who undergo surgery, by 5 to 10 years will return to their baseline body weight, because you can eat past your bariatric surgery. In terms of drug therapy, what's the downside? The downside is the cost. It's very expensive, and not many patients can afford it, and certainly no funder can afford to pay for every obese patient who requires the drug. But, as was mentioned, the Ozempic, for example, or semaglutide is coming to the end of its patent in India and China in 2026, but not in South Africa. But I think the drug will make its way from China and India to South Africa. And then once the cost of these drugs improve, then it becomes a lot more accessible. So the availability to all patients is limited. The initial GI side effects, as I said, are treatable, but they are there. 5 to 10% won't take it. It does need to be taken lifelong. This is very important. There are many people here probably who are taking it, who have relatives who are taking it, who think they can just lose some weight and then they stop the drug and everything will be fine. No. There is no such thing as I'll change my lifestyle and I'll manage to keep my weight down. You need to stay on the drug forever. It has been shown repeatedly, you stop the drug and within 6 months all of the weight loss is regained. Okay? So it is lifelong treatment, and then as discussed earlier, sarcopenia is a problem with any weight loss. You don't only lose muscle. So the upside to drug therapy is that you're getting the same amount of weight loss as surgery. It's safe. There's no special considerations and big reports and all sorts of things that you need to consider. You have the convenience of drug holidays. The patient is going to a fancy country where there's good food in Morocco or whatever it is. They stop the drug before they go on holiday so they can go there and enjoy the food. And they come back and then they go back on the drug. With bariatric surgery, no, you're not going to enjoy food ever again once you've had the surgery. You can, and then if you're losing too much weight with the drug, you cut back the dose. Whereas with bariatric surgery, some people lose and they can't stop losing. And it's a problem because they end up being cachectic and malnourished actually. So because the surgery is irreversible. So drug therapy, nothing is irreversible. There's no major morbidities and mortalities to worry about. It's a once-weekly treatment, painless injection, wide accessibility, and it works at all stages of the disease. We're now moving to micro-dosing to prevent obesity. So before you become obese, start a small dose, a fraction of the dose, to stop you from overeating so that you don't become obese in the first place. Which you can't do with bariatric surgery, by the way. So the role of metabolic surgery in 2025, if your BMI is really high, you might need it because the amount of weight you lose with the drug may not be enough. Take the drug, get to a weight, and then you might need to use bariatric surgery after that. If you're intolerant of the drug, then you'll have to do bariatric surgery. If you're a non-responder, there are a small percentage of patients who don't respond. Those who plateau, in other words, they're taking the drug, they lose, but they haven't reached their target weight loss, then you might consider surgery. Those who are not agreeable to lifelong therapy, and of course, if you consult a surgeon who needs to change his Porsche or buy a Lamborghini, before you consult the endocrinologist, you'll end up with surgery as well. So I think if you ask me, which is the silver bullet and which is the slippery slope, that's a very easy answer for me. Thank you very much.
Thanks, Aslam. There's a lot to swallow there. So we're going to ask Ebrahim straight on because we sort of run a bit over time there to present. Jazakallah.
I was actually thrilled to see the last slide because through the presentation I was actually confused about which one you were saying was a silver bullet there, but okay. And I'm not sure which bariatric surgeons he's been dealing with all these years, but things have changed a lot. So, these are not good procedures, they are exceptionally good procedures. And what you have to understand is that bariatric surgery has been around for the last 5 or 6 decades now. And we know all the problems and we've refined the procedures significantly so that we've actually obviated most of them. So just a bit on the surgeon's approach to obesity and a few opening remarks. Obesity is a chronic relapsing intractable disease and there's many variables. We concentrate on the modifiable issues like food and exercise, but there's the genetics, epigenetics, and a whole host of other factors, what medication the patient is taking, what underlying medical issues the patients have. And if you think medication is going to sort all of that out, dealing with a really complex disease, I think it's actually unthinkable. In terms of what we can offer the patient, what we impress to them is that it's actually a partnership between what the healthcare team can do for you and what the patient does for themselves. I think it's important to emphasize to them that the responsibility to lose weight is not on the practitioner, but is actually on the patient. And interventions are the most well-studied, safe, and efficacious, and that's clearly been shown over the last several decades. There's a move towards early treatment of patients using holistic guides versus BMI-based guidelines. You would have seen Dr. Amod speak about some of the BMI criteria. We've largely moved away from that. We can actually offer bariatric surgery from a BMI of 30 and above. And the thinking has been, if you look at the old criteria where you looked at patients getting bariatric surgery from a BMI of 40, a whole host of patients, millions of patients have lost out on interventions until the guidelines were actually revised. So the thinking is, if obesity is a chronic disease, and you know that when somebody starts picking up weight, they're going to pick up more weight in the future. Nobody's just going to stop suddenly and start losing weight. Why wait for somebody to get more sick? Why wait for them to pick up more weight before you can offer them a solution? And therefore, we're moving towards early treatment of patients. BMI is only one criteria, but we're looking more at body composition, fat percentages, and a whole host of other criteria in the recommendation of interventions and bariatric surgery. So traditionally there's been restrictive procedures, there have been malabsorptive procedures and combinations of the two. There's a restrictive component and a malabsorptive component of the procedure. And now we are moving towards more purely metabolic procedures where we don't want too much in terms of intestinal bypass. There's two key elements at a very gross level in terms of how the procedure works. We make the stomach smaller, that's what we call gastric reduction, and some element of small intestinal bypass. The real benefit of the procedure is actually in the metabolic change and not so much in restricting the amount of food you take in or how much of malabsorption there is, but actually in the pure metabolic improvements of the procedure. We see the caloric reduction, we see the reduced caloric absorption, microbiome change and metabolic change from the procedures. A lot of what Bilal spoke about and Dr. Amod spoke about in terms of the benefits of drugs and all of these things. It's essentially the benefits that come as a result of weight loss, and we've known these benefits for the last several decades already. And the goal now is not only on having a thin, lean patient, but we want happy, healthy, lean patients with a good quality of life. And the ethos and the philosophy of the surgeon is absolutely vital. If you look at how surgery works, we look at gross pathology. There's a malignancy in the stomach. You go there, you resect the stomach, you submit it to the lab, and the lab sends you a report to say, here's a malignancy of the stomach, and it's been completely excised, etc. And the thinking or the thought processes for the surgeon doing bariatric surgery has to be so on point, and that's why I say the ethos and the philosophy of the surgeon will ultimately, decide the eventual results of those patients, is because the pathology that you're dealing with is not seen pathology. You can see the obese patient, but the real disease process is the abnormal metabolism, and you're operating on a stomach that's normal, you're operating on an intestine that's normal for actual metabolic benefit and metabolic change. And as I mentioned, these are exceptional procedures, and really we must understand that no bariatric intervention fails a patient. It is rather the patient that fails the procedure. So, as I said, I don't know which bariatric surgeons Dr. Amod has been dealing with, about the laborious reports and all of that. Essentially, our bariatric patients get worked up in a day. We have a simple 3-step process at Al-Qadi. We do an up endoscopy, some bloods and an ultrasound one morning, and they have 2 other visits. They visit a physician to make sure their medical conditions are under check and they're safe for an anesthetic, and they see the dietitian to try and optimize the nutrition going forward. We don't insist on long pre-op liquid diets and pre-op weight loss. We feel it's a treatment paradox. If you can lose weight on your own, you don't really need our services. And with the psychological and psychiatric assessment, if the patient presents to you and they want to lose weight, that's majority of the psychological obstacle done there, because the patient has insight in terms of the fact that they need to improve their health and lose weight. So unless they have known psychiatric issues, we don't really insist on that. So the first intervention I want to talk to you about is the intragastric balloon, which I introduced in 2017. It is a fantastic intervention, done as a day case. Patients lose on average about 15 to 20 kilos in about 6 months with a bit of sedation, no cuts, no general anesthetic. It's put through the mouth, balloon goes in. 6 months later, we remove it via some sedation again. Super safe procedure, and we do a lot of intragastric balloons. We used to have adjustable gastric bands, which was restrictive procedures. There were many issues that were associated with the procedure. The band usually erodes the stomach. They have a lot of complications. So this has been largely done away with, and it's not something that we advocate, and is not really commonly done internationally. The sleeve gastrectomy is a procedure where we resect the greater curve of the stomach. It's a metabolic procedure because a lot of the satiety hormones, especially ghrelin, is contained in the greater curve of the stomach. And obviously the stomach is then restricted to a narrow tube, which restricts your calories as well. So a lot of the issues that Dr. Amod spoke about are entirely true, but as I said, we've learned from them. So the sleeve gastrectomy is only a procedure that we do in very young patients, adolescents, young female patients, in low BMI patients, and in that category of patients, it is really a fantastic operation. If you do an upper endoscopy in the workup and you find that the patient has a large hiatus hernia with some reflux, then it is not often that we do the sleeve gastrectomy, but I'll show you an instance in which we can. This is the instance. So in a sleeve gastrectomy, we have to remove the fundus. If you have a retained fundus, the patient can have inadequate weight loss, or they can have early regain. So you have to remove the fundus and the greater curve when you're doing a sleeve. But in a Nissen sleeve, we combine a Nissen fundoplication with a greater curve resection. So we leave a little bit of the fundus just to wrap around, just for the fundoplication part, but it doesn't partake in receiving food. So you're getting the weight benefit. If a patient has mild reflux, you can do this procedure, and it also obviates a lot of the reflux that you would get in a sleeve gastrectomy patient because it is a highly pressurized tube. We've now started the endoscopic sleeve gastroplasty, which is an endoscopic procedure. We're doing what the sleeve does, but we're doing it from the inside. There's nothing resected, but we are crumpling up the greater curve so that it gives you restriction. It is touted to be a bit better than the balloon, not as good as a sleeve gastrectomy. It's early days for us, but so far our results show that the results are equivocal in terms of the balloon versus ESG. So this is a good procedure. If a patient has had multiple abdominal procedures, you can't do any bariatric surgery procedure for them. They have a lot of intra-abdominal adhesions, and you can do it endoscopically. The issue with this, of course, is the cost issue. It is a non-surgical endoscopic procedure, but it's done under general anesthetic. So the use of the device, theatre time, etc., pushes the cost more towards the bariatric spectrum. So ultimately, you have the intragastric balloon on one hand, and you have traditional bariatric surgery on the other hand. But watch this space. ESG is going to do some good things in the future. Then the other issue we had with the sleeve gastrectomy, and this procedure was popularized by the Iranians because they had sanctions, they couldn't get access to staplers, but they had laparoscopic equipment. So they put a scope in, and then they sutured the greater curve in layers. So it's similar to what the ESG is doing, endoscopically suturing from the inside. Here we're suturing it from the outside of the stomach, crumpling it so that you get some of the sleeve gastrectomy effects. Then people said, we're using staples, it's very expensive, you can get staple line leaks, etc., etc. So the two companies came up with this device. One is called the bariatric and the other one is called the B-clamp, and it has a restrictive effect of the sleeve. This is a reversible procedure because you can take the clamp off. The sleeve gastrectomy in itself, really speaking, technically speaking, is not reversible because you can't put the part of the stomach that you resected back in. But over the next couple of years, the soft tissue of the stomach will expand and you will reach about 70 to 80% of your original capacity. So it is not really irreversible, but it is certainly partially so. The Roux-en-Y gastric bypass was traditionally the gold standard of bariatric surgical procedures and gastric bypass. We were also pretty much doing away with this procedure. Some of the issues with this procedure was you can see that the gastric pouch is too small. Patients couldn't eat, very well, and then they sort of comforted themselves with the fact that this is the price I've got to pay to lose weight and be healthier. But we've learned from this now because we don't only want lean patients, we want really healthy and we want healthy patients, and we want a good quality of life for them. So what we said was, let's try and make the stomach bigger, let patients eat more. And when we started to do that, we noticed from all of the data that increasing the size of the stomach made a happier patient, made them eat a little bit better, but you were not getting any reduction in the weight loss, and the patients were doing just as well, or even better, with the increased size of the stomach. Then the other issue with the Roux-en-Y gastric bypass was because you cut the intestine, there was now mesenteric defects. Patients were ending up with internal hernias and bowel obstructions. And the third issue we noticed was that although it was traditionally called a bypass, it was very restrictive by its nature. You had a small pouch, you had a small gastrorheginostomy, and this was very restrictive. And over time, the gastric pouch enlarged, and then what happened was that patients were able to eat more, and they picked up weight, and there was no options for reversibility in these patients. So the mini gastric bypass, or the one anastomosis gastric bypass, was also first introduced by our unit in South Africa about 5 years ago. It is a completely reversible procedure. We do not cut the intestine. It is an omega loop anastomosis to the gastric pouch, and we tailor the biliopancreatic limb to the patient's initial BMI and their comorbidities, and we have fantastic results in terms of weight loss. We have fantastic results in terms of comorbidity resolution, and as I said, this is a completely reversible procedure. And if you must know about compliance after bariatric surgery procedures, it is poor internationally. We don't really care. We want the patients to come back, but we don't really care if the patients come back or not, because if bariatric surgery is done well and the patients are eating a relatively nutritious diet, the risk of nutritional deficiencies is ridiculously low, and the vast majority of patients are not on multivitamin supplementation for the rest of their lives. These were other procedures that were done: biliopancreatic diversion and duodenal switch, very technically demanding procedures. We started to think, why must we do all of these technically demanding procedures? The weight loss is just as good with simpler procedures. Why to expose the patients to longer theatre time and more complications? So we've actually done away with this. Then you'll see there's sleeve plus procedures, just a term given to some of the bypass, where we combine a sleeve with some other procedure, and most of the time it's a bypass, what we call sleeve plus procedure. So we have many options available to tailor our surgeries and our interventions to the type of patients that we are dealing with. And then we have the SADI-S procedure and duodenal switch. SADI-S is basically you cutting the duodenum, you're doing the single loop anastomosis to the duodenum, very much similar to the one anastomosis bypass, and this relies on a very short common channel. It is not a favored or a popular operation compared to the Roux-en-Y or the one anastomosis gastric bypass, but more and more people are starting to do the SADI procedure. And as I spoke about pure metabolic procedures right at the get-go, transit bipartition is undergoing many studies at the moment, and essentially what we're doing here is that we don't want too much of a bypass. If you look at the picture, you will see that the sleeve gastrectomy is done to get some of the satiety, hormones, we want to reduce intake, and now in terms of getting proper bypass, the food has two channels. We can either go past the pylorus in the normal way, or it can go down the bypass limb into the small intestine. And usually what happens in procedures like this is most of the food will go into the small intestine, into the bypass area first, and then what happens is you reach a point where there's an ileal break, so which means food goes down the small bowel, goes, and then there's a break, and then food starts to go down into the pylorus. So one of the benefits of these procedures is that you have food going down the normal channel and the bypass channel, so the risk of nutritional deficiencies, especially if your common channel is not too short, your nutritional deficiency rate is very low. And the problem that we have with traditional bypasses is if a patient develops choledocholitis in the future, you don't have ready access to the biliary tree. Here, the access to the second part of the duodenum is maintained. You can still do easily an ERCP. Just a little bit on GLP-1 drugs before I conclude. GLP-1 plus, what I mean by that is now they've gone after GIP and glucagon peptides, etc. Cost and availability are issues. They are over-prescribed and abused. It's not a good thing that we can just write a prescription for these patients, because these drugs really have to be supervised by a professional who's monitoring them on a regular basis, checking their body composition. Are they losing weight, but are they losing fat, or are they losing muscle? There are side effects and complications. They're not well tolerated, nor are they desired by all patients. There's a ceiling effect, which means you lose weight, lose weight, lose weight. You're carrying on, continuing taking the medication, but you don't get any additional weight loss. And the plateau comes, and the patients then become disillusioned by the drugs. They stop the drugs, and then there is wild recidivism on sedation. Dr. Amod said that these are drugs that you must take forever. How do we know that? We don't know that we should take these drugs forever. Neither do we know that if we do take them forever, what side effects that will have. And if you do take them forever, you don't know if there's going to be any additional weight loss benefits in the future. So I don't know how anybody can say that this is something that we can take forever, except to say that obesity is a chronic disease. There is lack of long-term data. What long-term means to you, I don't know, is it 5 years, 10 years, but certainly bariatric surgery is way more established from a safety and efficacy perspective in terms of long-term data. Then we have the concept of multi-episode treatment modality versus a single repeatable. Bariatric surgery and a lot of these procedures is once off. It lasts you for as long as you need it or lifelong, as opposed to taking a drug which you inject in yourself on a weekly basis or daily basis. And it's difficult to tailor treatment with obesity medications because you only have certain medications and you have a wide spectrum of obesity patients with so many variables. Whereas with bariatric interventions, we have different interventions, we have different surgeries. We can do the same surgery in so many ways to be able to benefit the patient. And the question is it really as good, the medication, or is it just the shenanigans of big pharma? And I think what's important to realize is that many of the studies that you see are sponsored by the pharmaceutical companies. They're very rigorous in terms of going to the dietitian, exercising, etc., because they're getting all of these medications for free and you're getting these fantastic results coming out. But does this actually correlate with real world data? And I have to tell you, I haven't seen this. You give a patient a prescription and tell them, right, go off and do life and do family and go to the gym and eat properly and whatever, and see what results you get out of them. It doesn't correlate with the data that we are seeing from some of the studies. So in conclusion, bariatric surgery and bariatric procedures in general, surgery and endoscopic interventions are still very much the mainstay in terms of obesity treatment combined with lifestyle modification. We're now fast-tracking patients. The surgery takes 1 hour to 1.5 hours, extremely effective, extremely safe. Nutritional deficiencies are almost unheard of now. Complications are almost unheard of now. Most of our patients stay 1 night in hospital. The vast majority of patients actually stay in hospital less than 24 hours. And the future is exciting for bariatric interventions. We are not in the least threatened by obesity medications. There's advances in technology, magnets, hybrid procedures, which means we can combine endoscopic procedures and surgery. We want to use less staples, and there's also a focus on bypass length. What is the exact ideal bypass length for patients? It is a topic of ongoing research for the patient. So we do not see medications as a threat. We see it as supplementary and complementary to our interventions. We do a balloon. We have no qualms about putting a patient on weight loss drugs as well. If a patient has bariatric surgery and years down the line they have a bit of a plateau or they're starting to pick up weight again, we have no qualms about adding medical weight loss to these patients. So we see it as another tool in our armamentarium. And I think one has to realize that obesity is an extremely difficult disease to treat, and you must ensure that your obesity toolbox is well stocked, and that goes well beyond just a prescription. Thank you.
So we started a bit late and we were a bit over time, so I want to give each speaker like 1 minute. Is that okay? And then we'll open to the audience for another few minutes.
Thank you very much. So I love this slide that said these are exceptional procedures. No procedure fails the patient, rather it is the patient who fails the procedure. It sounds like surgery, the patient dies post-op. Surgery went well. His heart stopped. I mean, that's why. So, no. I think if a patient fails a procedure, it means the procedure was done inappropriately. I think that's the bottom line. And I must strongly dissuade people leaving here thinking that you can assess a patient's appropriateness or suitability for bariatric surgery, which is a lifelong procedure, in a few hours. Can't be done. If you're doing it incorrectly. So, because you see, as I said before, the surgeons don't see these patients 5 years later when they divorced, because the surgery was done, the patient lost weight, and the husband wasn't even on it, and he wasn't happy with the fact that his wife had bariatric surgery. So you might call it a successful operation, but the patient's life is failed. So you have to be careful. Patients who are suicidal, who have had a previous suicidal episode, you can't operate on those patients. So there is no shortcut to assessing a patient's suitability for bariatric surgery. So please, don't walk away thinking that you can just send a patient to a surgeon and the next day the patient is going to be having bariatric surgery. That is inappropriate as far as endocrinologists are concerned. In terms of just a few other things, I think the other thing is that other complications happen. You know, these patients replace food with drink. So alcoholism actually post-surgery is actually more common. So you have to be aware of all of these things. The other thing is that in terms of the mini bypass, I think we don't have enough long-term data. Gastroesophageal reflux still seems to be a major problem with that. So that's I think it's a good tool to add to the armamentarium, but we need longer data. In terms of the studies that we do, the drugs, there is no other intervention. I've been involved in all of the most of the studies on the GLP-1s for weight loss. Patients don't get to see a dietitian, they don't get any other advice. The only thing they get, you're either randomized to active drug or you're randomized to placebo. So the effects that you're seeing with the drug are purely the effect of the drug, not the effect of any lifestyle intervention. Drugs are safe, they can be stopped, they're reversible. I still think that that's the silver bullet. Thanks.
You know, whenever we have these discussions, you have to look at real data, not real anecdote. And the message that I want to put out here is that bariatric interventions should be more readily available. It should be done at a lower BMI. And if you look at obesity statistics worldwide, it is one of the highest ranking medical issues that we have. South Africa ranks in the top 5. In Africa, we are arguably the most obese country. So the fact of the matter is that we have a health problem that we have to deal with, but yet we're putting so many obstacles on the way. The fact of the matter is that we don't need laborious testing. We need testing. We're not saying that a patient comes to us and we're just going to have bariatric surgery. You have to assess the suitability of these patients. But I most certainly want to reiterate, these procedures are not great. They are absolutely fantastic. And I don't know about the data about the one anastomosis bypass. It is our favorite technique. It is a really, really good bypass technique. It is favored over the Roux-en-Y gastric bypass. It is done all over the world, including America. It's featured in all the guidelines. So I don't know how much more data you want, but I have to say I'm going to reiterate the same things. Bariatric interventions is still very much the mainstay of obesity treatments.
10 seconds. 10 seconds.
Fantastic, superb, all of these things, not one reference. You never saw a single reference, remember that.
Okay, so
There's this thing called the internet. You can search until you're blue in the face. Everything is a reference.
So, I realize when you're in your 30s, you come for CPD activities to network. When you're in your 40s, you come to actually learn medicine. When you're in your 50s, you come for personal reasons to sort out your own health problems. so shukran, today I got some guidance. I can go home and decide what to do, drugs or surgery. Okay, I'm going to open, there's already some. Sister Hani, you're so sweet. Ask another question.
Okay. I just would like to say
Gee.
My God, can you go on? Anyway, it is what it is, but in absolute keeping with the Islam, and Imam principles of this conference, let's be upfront and honest. Let's do that for a change. We don't need all those big farmers, we don't need all those surgical procedures, etc. I am an example. I tell you what, I'll be absolutely frank with you. 2 years ago, I said to myself, I taught myself, this 125 kilograms will have to jolly well go where it came from. And with the change of lifestyle and exercising, drinking lots more water, and being upfront and honest to myself, I am now 85 kgs. And I tell you what, I'll show it. I just would like us to understand that people are out there, and let's keep in our minds this absolute convention when we are trying to advise people. So thank you very much, gentlemen. Have a good evening tonight.
So that's perfectly true. I mean, there are people who will lose weight and manage to keep it off, and obviously the data shows that maybe there are not as many people as we would like. And perhaps the answer will lie in using drugs and surgery at the right time. So the right treatment for the right patient at the right time. And perhaps that will be the answer in the end.
Thank you very much for the comment, well taken. Look, I mean, we were asked to debate. The bottom line is these two modalities work together, and some patients are better suited to drug therapies and some patients are better suited to surgery. The point made about its lifestyle, no doubt it's lifestyle. The problem is that it's only 1 out of 1,000 people that can achieve what you achieved. So losing weight in 3 months and 6 months is very easy. Anybody can do it. 5 kilos, 10 kilograms in 3 months. The problem is who can lose more than 10% body weight and keep it off for more than 5 years. That's less than 1 in 1,000. Now we can't, if we were to use that approach, that it's lifestyle and the patients must just get on with it and do it, the majority of people will remain obese and we won't have any impact.
So we know for a fact Sister Hani is 1 in a million. So,
Sure.
gee.
I think when you speak about the bariatrics as a silver bullet, and I know it's a debate, I know this is take a stand and a position and hold it. I think that the psychological assessment around bariatric surgery is so crucial that you need months for that. I know there's a couple of psychiatrists in the room that deal with this. We deal with it as hepatologists because these patients are seeking dopamine. They're getting their dopamine from food. Now suddenly they don't get it, and suddenly they start drinking. And the damage that the alcohol does in the absence of a pylorus is immense. The acceleration towards cirrhosis with the sarcopenia leaves a lot of them untransplantable. So I think that before a patient has bariatric surgery, I think we don't understand what the intestine does. And if you look at some of like your duodenal resurfacing techniques and so on that are coming up, the fact that GLP-1s have only been identified in the last 15 years or so, 15 to 20 years, and that there are so many more molecules coming from the intestine. By us diverting as we are, I don't think we fully understand what we're playing with. So I kind of am on side medicine.
Look, I think as nephrologists and most physicians, we will have a perception bias because we will see the patients who come back after issues. So we've had patients post all the surgeries with the kind of kidney stones and kidney failure. You guys are seeing the NASHs. We recently had a patient whose BPD bypass was overdone and basically, as Aslam said, he malnourished himself to practically to death. So I mean, I think we're seeing that, but obviously we're not seeing the ones who are doing well. So it's difficult for us to judge completely. Is there space for a head-to-head? Will anybody ever do it? Who will fund it? I mean, at this point, the elephant in the room, I don't have the elephant in the room, I take it, okay? But the elephant in the room is, I don't think medical aid is paying for either at the moment, except in rare circumstances.
Now, your point is well taken. I don't think I must be misunderstood. Essentially, what I'm saying is that we have a significant obesity problem in this country. And instead of putting more obstacles, we need to look for avenues so that more people get treatment easily, so that we're reducing the obesity burden in the country. So don't put unnecessary obstacles in their path. If you're going to say every patient must have a psychological assessment, then essentially you're creating more obstacles. There are some patients who come who just don't want to see the psychologist. Are you going to, because of that one component, let me finish, is it because of that one component you're going to say now, we don't need to actually treat you, we won't actually treat your obesity? I don't think you can really say that. The other thing is that this has to be unpacked. If you say, the patient has to go to the psychologist, or all patients must go to the psychologist, yes, they must go to the psychologist, but for how many sessions? Must you wait 1 year? Must you wait 2 years? How much is enough for this patient? And I can tell you, it's not only my feeling, but all bariatric specialists around the world will tell you that when a patient comes to you, you'll have two types of psychologies. You'll have this type of patient who will be like super motivated, do this, I'm going to lose the weight, and that will be the patient who will disappoint you. And then you'll have another patient who looks very glum and pessimistic about things, and that's a patient who will surprise you, will be the most motivated patient. So if you look at all of the data in terms of patients going for psychological assessment and which type of patient will ultimately do the best, we don't have that strong data. It's very hard to predict that. So essentially, if a patient is normal, has a normal mental state, who comes to you and says, I recognize I have an obesity problem, I've tried for several years, several diets, lifestyle changes, etc. We know it's just not lifestyle changes. There are many other components to the obesity problem. And in a situation like that, this is a patient with great insight. They've already researched the procedures, they already know about the procedures, they already know about obesity when they come there because of the free access to information. So I think our thinking about these things has to change a little bit, and we mustn't be so rigid. The other thing also is when you're looking at bariatric procedures and most treatment modalities, you'll find that the vast majority of patients will fall within that bell curve. You'll have a few outliers on either side, and you cannot make routine changes in your algorithm based on that one patient who now stopped eating junk food and became an alcoholic. You understand what I'm saying? That's not what happens in most instances.
But it's not one.
No.
So it's data now.
No. It's not one. But if you look at it relative to the percentage of obese patients out there and the percentage of patients who are actually having weight loss procedures, it's still negligible. It's negligible enough to not change your routine practice, is what I'm saying.
Okay, we give you 10 seconds to get this done, and then we outline samosas and cold.
I don't think that you want to deprive people, but at the same time you don't want to take shortcuts. You're not going through that extra step is not going to deprive anybody. But if somebody is not wanting to go for a psychiatric evaluation pre-op, maybe they've got a personality disorder, and that's the problem. The problem is surgeons don't know how to diagnose a personality disorder. So the personality disordered patients, they're not depressed, they're not suicidal, they're not bipolar. A personality disorder will charm you. It'll make you feel like he knows exactly what he wants and so forth. But they're personality disordered. So, and they're the ones that run into trouble. So I think
we have to stop here. We have one last question. Most physicians and surgeons have separate types of personality disorder. both of which have been, all three of them which have been in the state today. This is a question from an ENT.
Yes, from Ian.
OSES.
So I'm
Start to sleep apnea.
Yeah, no, nothing to do with that. Thank you very much to the two speakers, very informative. Dr. Mansoor, I just have a question for you. In terms of medical aids and all your bariatric surgical procedures, do they actually pay for these procedures or do they see it as a cost?
You know, bariatric surgery has been in a very dark space in this country, because essentially you had a society in this country where it was a husband and wife combination, made a society, and they kept it as a very close-knit thing for all of these years. And essentially, you don't need accreditation for bariatric surgery. You must realize these bypass procedures, it's a partial gastrectomy, a Roux and Y gastric bypass. A patient with a stomach cancer, we do the similar procedures. We're just tweaking them for metabolic benefit, for weight loss benefit. So if you're a surgeon who has committed to learning about obesity and doing these procedures, you can do it if you can do it safely. That doesn't mean if you have accreditation, you're having better results or something like that. So to answer your question, it's a complex one, because for a long time, these guys held it just amongst themselves, and there were few people around the country, etc. And medical aid funding came down to who they recommended was allowed to do it, etc., etc. So ultimately, I have to say, in our unit, we don't liaise with the medical aids for bariatric, for balloons, for gastric bypass. We have patients who come to us, they're insightful patients, they have resources. If they need to have follow-up tests, they will come, they will have better compliance. If they need vitamin supplementation, they will be compliant on it, etc. The problem with dealing with bariatric surgery and dealing with medical aids in the context of our obesity situation in this country is a complex one, because essentially anyone for a BMI of 30, 35 will be like, I'm suitable, my medical aid is paying, operate on me. And that's where the problems come about. If you get too greedy with these procedures, if you're offering it to all the patients, you will end up with problem. And then that is a system problem or a practitioner problem. It's not a procedure problem. It's not a surgery problem per se.
Okay, I think there's more questions than answers here that have arisen. I'm sure you can all, both of you can, look, we've got a ring set up next door for the two speakers. I'm joking. But Jazakallah, I think that was a fascinating and engaging debate. I think it was well worth it. We went over time, but nobody left, so alhamdulillah. So I just want to thank all the speakers. I've got a little gift for all the speakers here. Otherwise I get to take them all home. So Bilal, Adam, Jazakallah for all your efforts, and thank you so much for contributing to the session, and thanks to the audience as well. Assalamu alaikum wa rahmatullahi wa barakatuh.